everyone, and a good night. From Singapore's point of view, we are 10 p.m. here. I greet you as we begin then the second of three webinars organized in partnership between ICE and Philaine dedicated to osteoporosis. Now, allow me to introduce myself. I am Dr. Vivian Lim, endocrinologist practicing in Gleneagles Hospital, Singapore. I sit on the committee of the International Society of Endocrinology and also am the chairperson of the educational working group of the society. To ensure success of these sessions from a logistical standpoint, I would like to mention some technical guidelines. To keep turned off microphones and cameras all the time. There shall be simultaneous English-Spanish translations which are available, and they can be accessed via the globe icon so you can listen into the language of your choice. We shall address the questions you submitted in advance during registration and also invite you to write your questions in English or Spanish during this broadcast in the chat at the bottom of your screen. Certificates of participation will be issued for this and each of the following webinars. Our streaming team will verify attendance at the end of each event. Each webinar will be broadcast live on Philaine's YouTube and Facebook channel and will also remain available on demand on Philaine's website and on ICE Education Hub. I will pass the floor now to Dr. Pilar de la Pena from Mexico, whom I have the great pleasure of co-hosting this particular session. Off to you, Dr. Pilar.
Thank you very much, Vivian. Good day to everyone. I greet you from Guadalajara in Mexico. I am Pilar de la Peña, endocrinologist, current president on behalf of Philaine, part of the Education Working Group and the Executive Committee for the International Society of Endocrinology. I am very pleased to introduce our speaker today, Professor César Libanati. He's graduated with honors from Universidad de Buenos Aires, then specialized in internal medicine, geriatrics, and mineral metabolism. Ex-director of the Osteoporosis Research Center focusing on basic, translational, and clinical osteoporosis and mineral metabolism. Author of over 130 research articles and book chapters. Member of professional skeletal societies and scientific reviewer for leading bone journals. He joined Amgen in California to advance the development, registration, and commercialization of Denosumab for the treatment of osteoporosis. After that, he joined UCB as head of global medical strategy and external affairs, leading the development and registration of Romosozumab. Currently works as a consultant specializing in bone and mineral metabolism, as well as drug development, registration, and commercialization. The title of his talk today is Denosumab and Romosozumab. Please remember that you can send your questions in the chat tool at the bottom of your screen. Thank you and welcome.
Good morning and good afternoon to all. I would like to first thank ISC and Philaine for the invitation to participate in this series of lectures. And I would also like to thank Dr. Pilar de la Peña and Dr. Vivian Lim for their introductions and coordination. My task today is in 20 minutes, provide an update on Denosumab and Romosozumab. And these are my disclosures. Denosumab, as you very well know, resulted from the discovery of ranglagin in the late 1990s. That led to the development of a monoclonal human antibody that inhibited ranglagin, and by doing so, profoundly decreased the activity and the birth of osteoclasts. In other words, Denosumab is a potent anti-resorber. And this characteristic of and mechanism of action of Denosumab leads and is associated with a particular effect on bone density, which is actually unique of all agents we have for the treatment of osteoporosis. And that is that with continuous administration of denosumab, you have continuous increases in bone density, both at the hip and at the spine. In this slide, in the blue line, you can see those increases in bone density that are unrelented up to 10 years. And in comparison, in green, zoledronic acid, in orange, alendronate, the bone density gains usually achieve their peak around 3 years, and from then on, there are no further gains in bone density. Now, why is that important? It is because we have always known that in untreated patients, BMD was a robust indicator and a risk factor for developing fractures. And over the last 10 years, there has been increasing evidence that the same relationship exists for patients on treatment. Shown on the graph for denosumab is the relationship between the bone density at the hip expressed in T-scores and the risk of having subsequent non-vertebral fractures. And as you can see, the higher the bone density at the hip while on treatment, the lower the fracture risk. And this relationship has now been shown to be very similar, or actually the same, for the bisphosphonate and for romosozumab. This relationship led to some treat-to-target recommendations that are increasingly being used and considered while we treat patients. And basically what they say is you need to try to achieve the higher bone density you can in patients that are at risk of having a fracture. If the bone density is already below minus 2.5 in terms of these scores, the treatment goal should be to at least achieve a bone density above minus 3.5. And you have to remember that the higher reductions in fracture risk are achieved when the T-score reaches values between minus 2 and minus 1.5. Now, that is so good for treatment with denosumab, those continuous increases in bone density. But another important differentiation or aspect of denosumab is that if you discontinue treatment, then there is a rapid and profound, again, decrease in bone density. This can be seen on the slide here. After denosumab discontinuation, the gains in bone density are rapidly lost. And this is the result of an increase in bone resorption when you stop denosumab. And as can be seen on the right part of the slide, serum CTX, a marker of bone resorption, rapidly increases, achieving levels above the baseline. There is a rebound in bone resorption and bone remodeling. And this is the result of the accumulation of Brand ligand, primarily the result of accumulation of Brand ligand throughout the administration of denosumab. Now, what is the problem with this is what has been now described in multiple series and well characterized in this study of almost 800 patients, and that is the development and the increased risk of vertebral fractures, and particularly multiple vertebral fractures during the discontinuation period, during that time when you rapidly lose bone density. And it's been shown that when you discontinue denosumab, the risk of having vertebral fracture increases to up to 10%, with 90% of those fractures, vertebral fractures, occurring in the first 12 months following the denosumab discontinuation, that is, after 6 months following the last dose of denosumab. Now, several series have identified risk factors for the higher likelihood of developing those vertebral fractures, and among those are a younger age, previous vertebral fractures, the duration of denosumab therapy, higher turnover at baseline, and greater BMD gains during denosumab treatment. This adverse event or adverse effect of denosumab discontinuation led to multiple attempts using different treatment regimens to prevent this loss in bone density and the increased risk of developing vertebral fractures. And in general, those have not been totally successful, but the present recommendation, that is the result of the ECTS, the European Calcified Tissue Society recommendations, with the goal of maintaining CTX within the premenopausal levels during that discontinuation time to mitigate BMD losses and to avoid vertebral fractures are the ones that we should follow, although more research is actually being performed in this arena, and the recommendations may change over time. However, at present, the best way to avoid that rapid bone loss and mitigate the likelihood of developing vertebral fractures post-denosumab discontinuation is as follows. If the patients have been on a short duration of denosumab treatment, that is less than 2.5 years of treatment, then giving an oral bisphosphonate for 1 or 2 years or 1 or 2 doses of zoledronic acid should be considered. And while doing that, monitoring BMD and CTX is important. On the other hand, if the patient has been on longer duration of denosumab, more than 2.5 years, then a dose of IV administered 6 months after the last denosumab dose, and close monitoring of CTX at 3 and 6 months, and perhaps also BMD as well. If these levels of turnover are above the premenopausal level, then repeat dosing of zoledronic acid should be administered. And in a recent publication from this year, utilizing this strategy, a small cohort of approximately 70 patients were able to reduce the amount of bone that was expected to be lost, and no vertebral fractures were observed. Again, we need more data, but at least this is important to consider if and when denosumab is to be discontinued. I always say that it is important to, when one considered starting denosumab, to have a very good talk with the patient and explain that you're kind of starting a therapy that is for a long time. And this is important because, unfortunately, we know that throughout the world, the persistence to denosumab treatment is in the range of approximately 3 to 4 doses. So by 2 or 3 years, less than half of the patients remain on denosumab. And this is, again, very important because with the advent of denosumab biosimilars, I would predict that a larger number of patients would be considered and start denosumab treatment. And therefore, there's also a possibility of a greater number of patients discontinuing it in the short or long term. So approximately 15 years after Prolia was first launched, we have now a number of biosimilars for denosumab available. As of to date, there are 7 biosimilars or pairs of biosimilars available for denosumab. They have been available and approved throughout many countries in the world, and the number of countries where denosumab biosimilars is becoming available is increasing on a regular basis. Now, moving into romosozumab, romosozumab is also a monoclonal antibody. It is directed and binds and inhibits sclerostin, a potent regulator of bone formation. And the interesting and characteristic action of romosozumab is that it exerts a dual effect on bone. Not only it increases bone formation, but it also decreases bone resorption. This is quite unique, and as can be seen in this slide showing the pattern of turnover changes, P1 and P in green, or formation in green, and resorption measured by CTX in blue, there is an increase in bone formation and a decrease in bone resorption. However, these effects last approximately 1 year, such as by the end of 9 to 12 months, romosozumab starts behaving primarily as an anti-resorber. And this is the reason why the treatment with romosozumab is just for 12 months. Now, this pattern of turnover is associated with the highest bone densities that can be achieved with any therapy. And just with 12 doses of romosozumab, you can achieve a bone density that is similar to that achieved by, for example, 4 years of denosumab therapy. And this is at the hip. At the spine, the bone density gains are even more impressive. By comparison in this slide, you can see what other therapies can do in terms of increasing bone density at the hip. And we already mentioned why bone density at the hip is such an important factor in terms of monitoring the response of therapy in a particular patient. This is another example of what can be now achieved with the agents we have, in particular, in this case, 1 year of a bone forming agent, romosozumab, followed by 2 years of denosumab, would achieve at the hip a bone density gain that approximates that of 9 years of continuous denosumab therapy. Now, the efficacy of romosozumab was checked in a couple, actually 2 large registrational trials, of which ARCH, the one that compared the sequence of romosozumab followed by alendronate in blue versus alendronate in orange, and can be seen in this slide in terms of fraction reductions, shows that this sequence, romosozumab followed by alendronate, over a period of 3 years, achieved significant and large reductions of vertebral fractures, non-vertebral fractures, and hip fractures, by approximately 50%, 20%, and 40% versus an active comparator, alendronate. And just to put things in perspective, I always like to mention that these reductions in fracture at all 3 key sites are similar, of similar magnitude, that those were achieved in the FIT trial of alendronate versus placebo. So we now know that the sequence of using a bone-forming agent followed by an anti-resorber basically signify a step up in efficacy from a sequence of therapy compared to what we used in the past, which was already a good regimen to reduce fracture risk, the bisphosphonates in general. This slide is, in my view, also an important slide because it illustrates both from FRAME, the study of romosozumab followed by denosumab, and ARCH, the study of romosozumab followed by alendronate versus alendronate, what can be the gains expected in density at the hip and at the spine. And in this slide, I am plotting the gains, the proportion of patients who gain BMD more than 6% at both the spine and the hip in the first year of the trial, just with 1 year of romosozumab. And as can be seen in the dark green area, approximately 45% of the patients achieve such large gains in BMD at both sides, spine and hip. Another 43% achieved gains of 6% at the spine only. They achieved gains in BMD at the hip as well, but they were not as large as 6%. An additional 2% increase the density by 6% at the hip only, not at the spine, and only 10% of the patients approximately failed to achieve 6% gains at both sides. Again, that doesn't mean they did not improve their density. The majority of them, particularly the spine, did. It just was not in the 6% range. And if you compare that in the same trials with alendronate, that at 1 year failed to achieve these gains in half of the patients approximately, and only 10% of the patients achieved gains of 6% or more at both the spine and the hip. Or interestingly, denosumab, which basically showed the same pattern than alendronate over the first 12 months of therapy. Now, why do I believe these data are important? Because when we individualize the therapy to different patients based on their initial or baseline density at the hip and the spine, we can now make decisions of which therapy to use. And this type of data plus the fracture data have now led to the recommendation from multiple guidelines that in patients at very high risk of fracture or patients with lower bone densities at the hip or the spine, starting therapy with a bone-forming agent, either romosozumab or teriparatide, or where available abaloparatide, and following the therapy with an anti-resorber such as bisphosphonate or denosumab is the therapy or the sequence of therapy that is more likely to lead to the larger gains in BMD and the larger reductions in fractures. Now, those large gains in BMD are achieved in patients that are naive of therapy, but we need to recognize that patients who have received a therapy in the past achieve smaller BMD gains. That is true for absolutely every single therapy. And here I'm showing from evidence from the real world what those gains could be and how do they compare to those patients who are naive of therapy if they have received first a bisphosphonate, or if they have received teriparatide, or if they have received denosumab. And in all three instances, you can see that the gains in BMD, both at the spine and at the hip, not shown this time here in the slide, the gains that are achieved are of lesser magnitude. Regarding safety, we can say that romosozumab is generally well tolerated. There could be continuous injection skin reactions such as pain, redness, or irritation. Those usually are manageable and do not necessarily repeat upon recurrent dosing. What is important to consider is that in one of the studies versus alendronate, an imbalance in myocardial infarctions and stroke was observed. This was not observed against placebo, and to date, with real-world post-marketing safety, this does not appear to be a significant change in the original evaluation of the safety profile. However, there remains a contraindication to not utilize romosozumab in patients who have that have a history of a MI stroke, depending on the geography in the world. That may be just a history of a MI stroke in the year before or ever in their lifetime. So in summary, I like to just remind everybody that denosumab and romosozumab result in the largest BMD gains of available anti-resorbers and bone-forming agents, respectively. Both have a proven fracture efficacy at all skeletal sites. Denosumab has been studied in clinical trials for up to 10 years with a proven efficacy and positive risk-benefit profile. However, it is important to know that upon discontinuation, there is a risk of increased vertebral fractures, and therefore we have to attempt to mitigate that by either not discontinuing denosumab. There's no reason in most patients why denosumab should or need to be discontinued, or if so, to follow the recommendations of using an agent to mitigate that bone loss. A number of biosimilars are now available, and their availability will continue to increase throughout the world. And for romosozumab, I like to emphasize that it must be followed by an anti-resorber. This is important to extend the fracture risk reductions that are achieved by the rapid and large gains in BMD. And with this short review and points, I would like to now finish my presentation and open up for any questions. Thank you so much.
On the train alone. Got to the hotel and Grandma was like, hey. I'm just like, what the hell are you doing here? What happened?
All right, thank you very much, Heather, for that very concise and yet very comprehensive talk. Let's take some questions from the audience. Let's see.
Yes, thank you very much. It was very nice. Thank you. Let's see.
I think we've got one question here. Do you continue denosumab if creatine clearance drops below 20? If not, bisphosphonates would be contraindicated due to poor renal function. And so, are there any other alternatives?
Yeah, that's not an uncommon situation that may occur in the elderly. So that's a good question. First, there's no contraindications to use denosumab in patients with renal insufficiency. Actually, there's no contraindications to even use it in dialysis. What has to be very careful, though, is about recognizing that there is an increased risk of hypocalcemia. So, in general, patients who have been on Prolia, who now develop some degree of renal insufficiency, there's really no reason for discontinuing denosumab, but you need to be aware of that risk and therefore manage their calcium balance extremely carefully. And that goes along with doing two things: ensuring that their vitamin D levels are, of course, well replete, sometimes increasing their calcium supplementation, and particularly monitoring them more regularly over the 2 weeks or 3 weeks that follow the injection of denosumab, when the risk for their developing hypocalcemia could manifest.
Thank you. Thank you. There's here a question about cardiac risk with romosozumab. So could you please comment on that, and at which level of PTH we can give teriparatide safely?
Okay. All right, let me first address the teriparatide question. In principle, in patients who have hyperparathyroidism, either primary or secondary, teriparatide should not be administered. Correct. In patients with secondary hyperparathyroidism, you first need to correct the secondary hyperparathyroidism, which is the result of a low calcium absorption or a calcium leak to the kidney. So the first step is to determine if the parathyroid is the result of a secondary cause or primary. In the case of primary hyperparathyroidism, there's no reason to give teriparatide, and actually you put the patients that are at risk of having hypercalcemia. Those patients with primary hyperparathyroidism will have, in general, elevated serum calciums, which is commonly how the condition is first discovered or diagnosed, and that needs to be resolved before considering giving any agent for bone. By the way, in my experience, in patients who have both primary or secondary hyperparathyroidism, and in particular those with secondary hyperparathyroidism, when the condition is reversed or corrected, the bone density, which may be in deficit at the time of diagnosis, improves very commonly on its own. So I wouldn't rush in those patients to treat them with any agent for bone. That's in general. Regarding romosozumab and the cardiac risk, the company and the world was faced with a conundrum, which was the fact that in one study, there was an imbalance in the risk of having or suffering a ACE event, or particularly a myocardial infarction, or ACV, a cerebrovascular accident, a stroke. And in another study, the FRAME study, which was twice as large, there were absolutely no imbalances. Now, that led to the contraindication across the world to not use the drug in patients who have had an MI or stroke before the consideration for the administration of romosozumab. However, we need to realize that that is not really based on the fact that those patients will have a higher risk of developing a stroke or MI. It's based on the fact that if the risk is to be real, which we still do not know, there are ongoing surveillance studies that are being done throughout the world, particularly in the US and in Europe and in Japan, that to date have not shown that the risk is significantly increased. But if the risk were to be real, then by using the drug, at the societal level or at the population level, there will be less number of additional cases of MI or stroke that were related to the use of the drug. So it is one of those conditions where we do what we believe is the best thing for overall the population by avoiding to use or contraindicating the use of the drug in patients who've had an MI or a stroke. So what will happen with as we learn more about the use of romosozumab in real life? We are awaiting the communication, which should probably happen by the end of next year, regarding the results of the large post-marketing surveillance studies that are being done and will compare in similar patients what is the actual observed risk in real life of having an MI stroke or a cardiac death in patients who receive romosozumab compared to similar patients who received other therapies for osteoporosis. As I said, until now, otherwise we would have heard from it if there were any imbalances. It appears that no imbalance have been seen, but we'll have to wait a little bit longer. And until then, continue to use the drug as indicated per label across the different areas of the world.
Thank you.
Just a small extension of that, because one of the audience did ask whether he could restart romosozumab after 1 year of MI or stroke. What are your thoughts on that?
All right. So we always need to treat every patient individually. We do as doctors, correct? So it all depends on what we believe is the risk of having another major fracture versus the risk of having a significant event as an MI or a stroke could be. It is also interesting to note that depending on where you are in the world, you are allowed to use romosozumab just within 1 year of having had an MI or stroke, like is the case in most of the countries in the eastern part of the world and in the US and in Canada, or you can never use it like it is in Europe. In Europe, for example, per label, if you ever had an MI or stroke, you're not allowed, it's a contraindication to use romosozumab. Whereas if you are in the US, if a stroke was 1 year or 1.5 years ago, in principle, according to the label, you can use it. We need to use our best judgment. When I have interviewed many of my patients who have suffered osteoporotic fractures, many of them have told me, listen, to have a heart attack nowadays is not as severe as having, for example, a vertebral fracture, because of the pain that you endure, because of most cardiac events nowadays are easily treated if you're within a system that has access to a good medical care. So it's a matter of personal belief and communication and interaction between the patient and the doctor.
Unfortunately, in Singapore, it's a contraindication. Once you've got a Am I?
Oh, yeah. Oh, okay.
Follow
Yeah,
Europe.
that's
Follow
yeah,
Europe.
yeah. It follows Europe. So that depends in country after country. And again, I think the right thing to do there is to use your best clinical judgment, because if anything were to happen to the patient, and it can, then you would feel bad for the patient and yourself. So yeah, you're stuck there with the label.
Yeah.
Thank you, Cesar. There's another questions here about could you please comment about the useful tool of DEXA, and also if is a must to bridge to another osteoporotic drug after 1 year of romosozumab? So there's two different questions here.
Yeah. So the first part that I want to make very, very clear, yes, it is a must to use another drug, an anti-resorber usually, after you use 1 year of romosozumab. The same way it is a must to use an anti-resorber after you completed your teriparatide treatment or your abaloparatide treatment. I go to say further that this discussion should happen with the patient if you're considering starting an anabolic or a bone-forming agent. You should never start a patient on teriparatide, abaloparatide, or romosozumab without talking to them and telling them that, okay, this treatment will be for 1 year or 18 months or 2 years, depending on the therapy. But after that, we need to already decide or kind of decide that and agree that you will need to take another therapy. Correct. So that is a very important point, and one that is a must. Otherwise, you're really not doing what is correct from a, not only guideline point of view, but from a medical standpoint. Regarding the other question, which was the utility of DEXA. All right. So where should I start here? Let me start with this. Like for any test in medicine, you should only do it if you know what you're going to do once you get the result. So doing a test for the sake of doing a test is absolutely a no in medicine. We all have hopefully been trained that way. And then I always say there's tests and there are tests. And I'm a firm believer that we are blessed in the area of bone disease that by having a tool such as DEXA. Talking to cardiologists, they would kill to have a test to predict the likelihood of having a cardiac event as good as DEXA is to prevent a fracture. And we don't realize the importance of that. So DEXA is extremely good to first determine what your baseline risk for fracture is in your patient. It's not the only way, but it's a very important way. And of all the risk factors that determine the fracture risk, the only risk factor that can be really changed that will have an impact is bone density, correct? What are the three factors to increase fracture risk? Your age, the fact that you've had a fracture, and your bone density, correct? With those three, you basically determine what your risk for a fracture is. Well, age, you can never reverse it. If you had a fracture, it's already a done deal, correct? That sets your fracture risk at a particular level, but the bone density can improve, and it's the only thing that you can improve. And it turns to be a blessing that we now know that when you improve your bone density in a therapy, you proportionally reduce the risk of having a new fracture. So to me, the value of following up a bone density lies on exactly that it allows you to determine where you are or where your patient is regarding not only if the patient improved or didn't improve. I mean, at the spine, basically 100% of the patients improve with romosozumab. If you wait 2 or 3 years at the spine, 100% of the patients improve with denosumab, correct? So the question is not, has the patient improved, but how much has the patient improved so that the bone density now has achieved a particular level that you feel comfortable saying, I don't need to continue to gain more bone density. I can now work on maintaining the bone density at a level where I achieve, or I need to continue to improve the bone density in order for my patient to further reduce the risk for a fracture. So if you use the result of a bone density that way, which in my book is the way it should be used, then it is extremely valuable. I hope that answers the question to whoever asked for it.
So, as a follow-up to that question about bone mineral density, so now if you start with a bone mineral density, which is abysmally low, minus 4.5, and we all know then that, although you can start with romosozumab for 1 year, it's not going to be treated to target, especially if this person is 80 years old, 90 years old. So what would then be the optimal plan? In the romosozumab, we go to what? And then from then, what do we do then? Let's say, especially if the T-score of minus 4.5 is at the hip.
Yeah, Vivian, that's a very good question, an important one, and one that we face in clinical practice, unfortunately, quite commonly, particularly in the older patients. So the answer to that is that we hope that we, in the future, will have the availability of agents that can improve bone density to a higher level of gains, correct? And I believe a few weeks ago, learn about new potential drugs on that are targeting not only the sclerosing pathway, but the DKK1 pathway that have the potential, we hope so, of further gaining more bone density than even the drugs that we have nowadays can do. So we hope for that. And I always say, let's be optimistic, let's build it, and they will come. So the more people realize that those gains in bone density are key to reduce the risk of fracture, the more interest there will be in societies and in drug companies in continuing to invest in the field. It's a little bit like what happened in diabetes, and most of you or all of you are endocrinologists, and you know that what really changed the world in diabetes, which was a dead specialty just 15 years ago, and nowadays is thriving with companies and new mechanisms of actions and new drugs, is the fact that a goal for a therapy was reached. You need to achieve a hemoglobin A1C below a certain level. And that became the law of the land, and that is what revolutionized and made drug companies invest again in the field. The same thing will happen and may happen in the field of bone. If we all keep stating that, hey, if we achieve these targets, which nowadays may be difficult to achieve, if we achieve these targets, then that's what we need to aim for in terms of curing or improving the risk of fracture in many of the patients. So there is a medical need. So that's hopefully the hope for the future, which may not be that far away, by the way, we hope. But what do you do in the meantime? On the meantime, I think if you're really, really interested in doing things, and I know this is difficult, and this is not following quote unquote necessarily the labels, but there are ways of further improving bone density. For example, if you push higher doses of teriparatide, like the study that Ben Letter did with double the dose of teriparatide, correct? 40 units instead of 20, 40 micrograms instead of 20 per day. And you co-administer the denosumab, which prevents the increase in bone resorption that teriparatide will do, you gain more bone density than even you do with romosozumab nowadays. The study was not head-to-head, but you can compare the bone densities, and I urge you to review that. So that's one way of doing it. Now, teriparatide, you used to be able to only give it for 2 years. Now there's no limitation on the use of teriparatide. So if you're really, really, really trying to do the best for your patient, maybe, and your patient need an extra boost in their bone density, maybe an option is to do that. Give higher doses of teriparatide with denosumab for longer periods of time. There's also the possibility of using again Romosozumab, which has been tried, and I think there's a couple of at least, if not case reports, there's a couple of abstracts on patients who received in Japan. Most of these post-clinical, post-study experiences coming from Japan, where they are now repeating Romosozumab after giving Denosumab or giving bisphosphonate. Now, the problem there is that with the bone-forming agents, in general, when you give something in between doses, the gains in bone density are not as high as you would achieve with the first dose. So that's something that people are trying to figure out how to overcome this decrease in the bone-forming capability of these agents once you have provided another agent in between, which, by the way, in theory, will be very difficult to achieve, at least with the knowledge we have to date, because with all the therapies for osteoporosis, the higher the baseline bone turnover, the higher the gains in bone density. That is true for absolutely every single drug. So if you are giving a patient bisphosphonate or denosumab or whatever, by bringing down the turnover, you will have, by definition, a lower improvement in density in the follow-up therapy. So, on the meantime, the thing to do, as I said, if you're not capable of trying these more experimental things, is to give the most powerful of the bone-forming agents and then follow with the Denosumab, which will continue to increase bone density over time. We have published what are the probabilities of decreasing or improve or reaching a particular bone density T-score with, depending on where you start, with these different sequences. That has been done with the sequence of Romo followed by Denosumab, Romo followed by alendronate. The first author on that paper is Felicia Kosman, and also on the I'm a co-author on that paper. And then it's been also been now published for the sequence of abaloparatide followed by alendronate. The first author on that paper is also Felicia Kosman. So you can look at that and then plan, and by following up the bone density, see how well or not your patient is responding. And then the last thing to do is, of course, to try to reduce the risk of falling, correct? Because at the end of the day, all these fractures occur in the context of some level of trauma, except for the vertebral fractures that can happen spontaneously. The other ones require even minor trauma, some degree of trauma. So preventing and being very careful about falling, there's things that can be done, should in theory reduce the risk for that patient.
Thank you. Thank you very much, Cesar. How many years do you think patients can use denosumab without interruption?
Right. Excellent question. When we developed denosumab, we were concerned about the fact that these patients were having extremely low turnover for a long period of time. Some opinion leaders in the world were worried that would cause a skeletal that will develop some fragility. We had reasons to believe that would not be the case, but because it was the right thing to do, we designed and we conducted a 10-year study of continuous denosumab administration. Those results have been published, and those results have shown that not only there's no skeletal problems by using denosumab for up to 10 years, but also that the bone density continued to increase, and that as the bone density increased, the risk of fracture further decreased. So bottom line, 10 years, the clinical evidence is there. Mm-hmm. There's nothing different between 9, 10, 11, 12, 13, 14, 15 years in terms of biological response. So while the studies have not been done, there's, in my personal view, no reason to stop denosumab for whatever amount of time you'll need to use it. Particularly now that we know that if you discontinue denosumab, and particularly if you gain a lot of bone density, the risk upon discontinuation of having vertebral fractures is quite significant. So when you put all that in the scale, until more evidence is known, I see no reason not to continue to use denosumab, and I see many reasons to not recommend discontinuing denosumab unless you're very sure of what you're doing, you're monitoring the patient, and you're trying to work, like we mentioned on the talk, the known expected reduction in bone density that will follow.
Follow up to that question, since we are discussing about, taking off denosumab. Now, the patient happily reaches a T-score of minus 1.5. Okay, so it's time that we change, but this is after 9 years of denosumab, let's say. People are living older and longer now. Now, my concerns then, if we switch over to either oral bisphosphonate or IV bisphosphonate, I know that you mentioned IV bisphosphonate, and to check the C-talopeptide, CTX. Now, the CTX, you mentioned premenopausal range, but the range, well, at least in my lab, is very wide. And it can go up to, a premenopausal can go up to 0.7, 0.8. Now, I have patients, before they're given denosumab, they are virgins to any osteoporotic drugs. The CTX is 0.2, 0.1. A lot of Asians are like this. So saying that you keep it in premenopausal range, it's not a good idea, for at least not for these patients. So what would you suggest then to truly for these group of people then? How do we observe them? What do we do? Then after you have, let's say we give zoledronate, how long further do we monitor them? If it goes up, I give a second dose. Then do I keep monitoring them every 2 months? What is your protocol?
Yes, excellent question, Vivian. So I will tell you a little bit. First, as I mentioned in the talk, you can follow the recommendations from the ECTS, which are probably the most vetted recommendations up to date. However, I have to admit, I'm retired now, so I presently don't see any more patients, but I did until not too long ago. And that's not even before the ECTS guidelines had been published, and that is not exactly what I do. And I'll tell you why I believe that's the case, and that's another alternative. First, let me congratulate you and the patient for having achieved that bone density. Which is very good. That patient is what I would say cured from having osteoporosis, and she would be expected to have a fracture risk of approximately 0.5 to 1% per year, which is the fracture risk in postmenopausal normal women with normal bone density. So a fracture can still occur. The risk is low, in the range of 1% per year. So that, again, first, congratulations. The second one is you want to keep that patient there, or have them moved their bone density with a little bit of fluctuation. They can decrease or increase a little bit over time. So there's several possibilities. The first one is to consider, and that has been done by a group in the Nordic countries, considering either decreasing the dose of denosumab or spacing the dose of denosumab, like, for example, giving it every 9 months or every 10 months. And again, now we're dealing with not sufficiently clinical data, but it's good. And if you did that, it'd be important to perhaps do it in a little bit of a controlled way, so you can publish the results eventually and help your colleagues that will be facing that situation. So that's one option. The second option is to, if you want to discontinue the denosumab, and as I said, even if you reach minus 1.5 or so, you need to decide based on the age of the patient, is it worth discontinuing or even continuing it, correct? You don't discontinue a blood pressure medication or a diabetic medication once you've reached your targets. You continue to treat them. And if you're going to use zoledronic acid instead of denosumab, what's the difference in terms? You're not. What are you afraid of? Correct? You're using another potent anti-resorber instead of using denosumab, zoledronic acid. So, what's the rationale behind that change? That's something to consider. Now, what I've done in my practice is in patients who I needed to discontinue the denosumab for very unusual reasons, correct, is to use an oral anti-resorb. And I use alendronate, but I didn't use it on a weekly basis. I use it on a daily basis or every other day. The reason for that is largely theoretical, which is once you discontinue the denosumab, the amount of RANG ligand, increased RANG ligand in your body is significantly, very significant. And therefore, that RANG ligand will force osteoclasts to come to birth on a second by second basis. So as the denosumab is disappearing, that RANG ligand is activating osteoclast precursors. We still do not know to what extent the osteoclast precursors are there at an expanded rate or an expanded pool or not. It doesn't matter. What we know is that those osteoclasts will come to life from wherever they're coming, correct? And in a period of minutes and hours, there's hundreds of thousands of osteoclasts that are landing in your skeletal surface. Now, if you give one dose of zoledronic acid, those will target the active osteoclasts. They will make them reduce their function. But the next day, or within 2 or 3 days or 4 days, when the zoledronic acid is either being deposited in your bone surfaces or the bone surfaces that were open, correct? Not the inert bone surfaces that were covered by lining cells. Those were protected by the lining cells, or disappear from the circulation because you basically urinated whatever zoledronic acid was left that was not absorbed into bone. What will prevent these osteoclasts that are coming to life to seed on your skeletal surface and cause resorption? Nothing. So it is not unexpected that bone density will continue to decrease, as it's been seen in every single study of zoledronic acid post-denosumab discontinuation to date, regardless of how you give it. And we know that you have to give more than one dose in the majority of patients. Bentelangdal tried that, but at the end of the day, they all end up losing bone density. So what I urge somebody to consider is instead considering giving, for example, alendronate. The 35 milligram dose is not available anymore, I think, anywhere in the world, but if it is, consider that. But why not use 70 milligrams every day, at least for the first few weeks after the 6 months past the last denosumab dose? That daily dose of bisphosphonate will prevent, in theory, those active osteoclasts on a daily basis to come to life. And for those that are concerned about using higher doses of bisphosphonate orally, let me remind you of what was the approved dose for alendronate for Paget's. The approved dose of alendronate for Paget's was, remember, 35 milligrams every day, correct, for a long period of time. So from a safety point of view, there's no risk of, there's no any problems of trying to use that. And that's something you may want to consider for that very fortunate patient who achieve a cured bone density deficit. And for whatever reason, you're worried about continuing denosumab. Now, again, you're exchanging denosumab for a higher dose of another anti-resorber. So again, what is the rationale for that? I'll let you think about that one as well.
Cesar, thank you very much. We are almost run out of time, but we have to invite you again to be with us and continue with the discussing.
Well, anytime. Thank you so much.
Thank
This
you.
has been wonderful and very good questions, by the way. Very practical questions, very important questions.
Of course, thank you. So yes, maybe we have to close. Vivian, what do you think? Or continue?
Yeah.
Or no?
Yes. No, I wish I could continue for another 30 minutes because there's so many
Yes,
questions coming.
exactly.
The audience, wonderful. You
Yes.
know, everyone's willing to answer. And I think we haven't finished the questions, the practical questions, as
Yes.
to why we wanted to change. Because everybody wants their drug holiday. And also the worry that if you keep using denosumab, what happens? You get minus 1.0, you get minus 0.5. I mean, if we face that, sooner or later, we'll have
Yes.
to change. So, you know, so many things, so many discussions to be had. But I think that, yes, we have all good things must come to an end. I hope that we have that Dr. Pillar would discuss about the next session. But this was beautiful. Thank you very much. It's 11 p.m. for me. This will keep me awake. Thank you. This is a wonderful session. Pillar, over to you.
Thank you very much. So thank you all, and I'm very pleased to invite you all to the participation in our next webinar in 3 weeks with Dr. Michael McClung. He will speak about the overview of the drugs we have available to treat osteoporotic patients. So don't miss it, and thank you very much. Cesar, maybe you want to say something.
Well, I want to say just have a wonderful day, a wonderful week, and I thank you for the invitation. It's been wonderful. So anytime I can be of any help, just don't hesitate to let me know.
Thank you. Thank you very much. Have a nice weekend to all.
Bye-bye.
Ciao.
Bye-bye. See you.